Hello, I am Dr. Keith Burke, a professor of behavioral sciences in the Alcohol and Other Drug Studies program at San Diego City College. The AODS program is a fully accredited college-level coursework program that is designed to train students in the required coursework needed to become a certified alcohol and drug counselor in California. Today, I'm going to be talking about treating clients with co-occurring disorders in substance use treatment facilities. There are expectations for alcohol and drug counselors who are working with clients who have co-occurring disorders. The United States Substance Abuse and Mental Health Services Administration, or SAMHSA, has established a policy statement in which they say that, quote, people with mental illness are likely to have comorbid substance use disorders and vice versa. Addiction counselors should expect to encounter mental illness in their client population. So the expectation for alcohol and drug counselors is to treat clients who also are going to likely have mental health symptoms and or psychiatric diagnoses in a substance use treatment program. So to treat a client with mental health symptoms, that means that you will provide assessment for that client, treatment planning for the client, provide individual and group counseling, medication management, and potentially case management. The alcohol and drug counselor is expected to participate as a key member of the integrated treatment multidisciplinary team. So a multidisciplinary team may include mental health clinicians, medical staff, administrative staff, residential staff, particularly in a residential inpatient treatment facility. So the AOD counselor is a member of the integrated multidisciplinary team and is expected to design and implement comprehensive case plans for the clients with co-occurring disorders. It is very important to note that the alcohol and drug counselor's role on the multidisciplinary team is to be the expert when it comes to treating substance use disorders for clients who have co-occurring disorders. It's worth noting that in the City College Alcohol and Other Drug Studies preparation program, the AODS student receives 645 education and training hours in substance use disorders and addiction treatment. Most doctors, nurses, social workers, marriage family therapists, and psychologists receive very little education in addiction. Doctors and psychiatrists, in fact, receive an average of 3 to 12 total hours in addiction education while they're in medical school. Compare that to the 645 hours that an alcohol and drug counselor receives. 90% of the MSW programs, which are the Masters in Social Work programs that licensed clinical social workers take prior to getting licensed as a mental health clinician, 90% of those programs do not require a standalone course in substance use disorders. So they'll get some education in substance use disorders, but they don't even take one class in substance use disorders. Whereas again, an alcohol and drug counseling student receives 645 education and training hours. Thus, on that team, psychiatrists are expected to be the experts, particularly when it comes to medications. Clinical psychologists would be considered the experts when it comes to treating the more severe and persistent mental illnesses. But on a multidisciplinary team treating co-occurring disorders, the alcohol and drug counselor is considered the expert in the treatment of substance use disorders. So with that, the alcohol and drug counselor is expected to conduct initial and ongoing screenings that will help identify clients with mental health problems or symptoms that warrant further attention. The AOD counselor is also expected to conduct basic formal assessments. So a formal assessment is something like a written document that has a set number of certain specific questions that are trying to get answers that can be used to create a treatment plan. So the AOD counselor is expected to do these kinds of formal assessments that will gather information that may provide evidence of a co-occurring disorder. So the alcohol and drug counselor will treat clients who have mental health symptoms. They will also assess clients who have mental health symptoms. This information will likely be used during clinical case consultation with other members of the treatment team, and it may be used as the basis for psychiatric and emergency-based referrals. Look, this is the truth of what happens in most substance use treatment facilities. Even if that facility has an on-site psychiatrist, an on-site licensed mental health clinician, it is typically the alcohol and drug counselor who will be doing the initial intakes. And in those initial intakes, they will be, again, screening and assessing for mental health symptoms. So what will often happen is after the intake, say that a client during the intake is responding to some kind of internal stimuli, and maybe she's hearing things that you don't hear, or she's looking around and seeing things that you don't see, then what will happen after the assessment is you will bring that information forward to the team member that's most appropriate, the psychiatrist or the mental health clinician, to discuss what should happen next. And sometimes your assessments may lead to psychiatric and emergency-based referrals, such as contacting the PERT team, the Psychiatric Emergency Response Team, if a person appears to be in danger of hurting themselves. Note that the alcohol and drug counselor will not make new, formal, independent mental health diagnoses, meaning that if a client comes in and does not have a diagnosis of, say, PTSD, an alcohol and drug counselor cannot put into the medical record a new diagnosis of PTSD. That's considered outside of the scope of the drug and alcohol counselor. However, drug and alcohol counselors are expected to diagnose and verify substance use disorders using the DSM-5 criteria that's established to determine a substance use disorder. Now, I recognize that there are some programs out there where the program may have a licensed mental health clinician who's also diagnosing substance use disorders. And in fact, there are some programs that use funding dollars from California State Drug Medi-Cal money, in which it may be a policy to have the mental health clinician diagnose the substance use disorders. In that case, they may simply have the alcohol and drug counselor verify the substance use disorder. But it's important to understand that by California state requirements for alcohol and drug counselors, all alcohol and drug counselors are expected to diagnose substance use disorders. It is a very important part of treating people with substance use disorders, because if you can't diagnose them appropriately, it becomes much more challenging to develop an appropriate treatment plan. The alcohol and drug counselor is also expected to be familiar with all of the major mental health classification groups, meaning that a drug and alcohol counselor should be familiar with what major depressive disorder is. They should be familiar with what post-traumatic stress disorder or PTSD is, and schizophrenia, etc. Additionally, the alcohol and drug counselor is expected to know what the general symptoms of mental health problems look like, to understand what responding to auditory hallucinations looks like, to understand what symptoms of obsessive compulsive disorder look like. Now, that's not something that we'll be covering in this first introductory lecture, but it will be a lecture that's covered further on down the line in the semester. The alcohol and drug counselor is also expected to be familiar with and practice the major evidence-based treatment skills recommended for people who have co-occurring disorders. So evidence-based treatment skills means that these are techniques or treatment interventions that have been used and studied and have been proven to work. So there are many of them that are recommended best practices for treating co-occurring disorders. Some examples of those include things like motivational interviewing, cognitive behavioral therapy, harm reduction, etc. So let's review this first section on the treatment of co-occurring disorders in substance use treatment facilities. So if you are an alcohol and drug counselor, can you treat a client who has schizophrenia and an alcohol use disorder? The answer is absolutely yes. There are many clients who have schizophrenia and other psychotic disorders. Psychotic disorders is a phrase used in the DSM, who will also be in treatment for a substance use disorder. That person will be in groups with other people who have substance use disorders. That person may be your client that you're meeting with. So you absolutely, within your scope of practice, after you've been trained, can treat a client who has schizophrenia and an alcohol use disorder. If you are an alcohol and drug counselor working on a multidisciplinary team and you think that the client's substance use is interfering with her medication, are you allowed to tell the psychiatrist that? Without a doubt, you're allowed to do that. Again, psychiatrists get very little training in medical school on treating substance use disorders. Psychiatrists are experts on medications, but they may not necessarily understand how a particular medication may be interfering with the client's substance use treatment. For example, the client might be in treatment for a heroin use disorder, and a psychiatrist may prescribe a benzodiazepine to the client to help treat their anxiety. So benzodiazepines would be very vulnerable for a person who has an opioid use disorder for potential cross-addiction, or the use of the benzodiazepine may lead back to using heroin in a problematic way. So it is not only okay to talk to the psychiatrist about that, it's a requirement for the alcohol and drug counselor, who's the expert, to talk with the psychiatrist about medications that may interfere with substance use treatment. As an alcohol and drug counselor, are you allowed to ask clients about mental health symptoms, including whether they have a diagnosis and what medications might they be taking? Again, absolutely. It is within the scope of practice and an expectation that alcohol and drug counselors will do screenings and assessments that may determine mental health symptoms. And we certainly need to know, does the client have a diagnosis and what medications might they be on? As an alcohol and drug counselor, are you allowed to diagnose clients based on DSM-5 criteria? For substance use disorders, it is a definitive yes. It is within the scope of practice for an alcohol and drug counselor to diagnose a substance use disorder based on DSM-5 criteria. The one thing that an alcohol and drug counselor cannot do is create a new mental health diagnosis based on DSM-5 criteria. That's outside the scope of the alcohol and drug counselor. If you think one of your clients is showing symptoms of PTSD, can you bring that up with the mental health clinician who works with you on the multidisciplinary team? Yes, absolutely. In fact, in many cases, the mental health clinician may be seeing the client once a week at best, but this client, again, is going to be in groups and other types of treatment activities where they may be showing symptoms that other people on the multidisciplinary team may or may not be aware of. So if you see a client that has symptoms that look to you like they are PTSD, you should definitely be bringing that up with the mental health clinician who's working with you on the multidisciplinary team. If you are working with a client that has a co-occurring disorder, can you use cognitive behavioral therapy in your treatment with him? Yes, as long as you're trained in cognitive behavioral therapy. So the only ethical requirement is that drug and alcohol counselors only use clinical techniques for which they've received training. There is nothing that says cognitive behavioral therapy can only be used by mental health clinicians. So if you are trained in cognitive behavioral therapy, then you should use cognitive behavioral therapy. If you're trained in dialectical behavioral therapy, then you should use dialectical behavioral therapy, etc. Okay. So let's talk about an overview then of what co-occurring disorders are and how to treat them. So co-occurring disorders were formerly called dual diagnosis, amongst many other phrases. That's now considered to be an outdated phrase. It's now referred to as a co-occurring disorder, which typically refers to disorders that are co-occurring or happening at the same time. And the two disorders in particular, two or more that we're primarily concerned with, is substance use and mental health or psychiatric disorders. Note that a co-occurring disorder may include one or more substance use disorders and one or more mental health disorders. For example, a client may have a methamphetamine use disorder that is in sustained remission, but an active opioid use disorder, and they have a diagnosis of major depressive disorder, and they have a diagnosis of post-traumatic stress disorder. In that case, you'd have 4 diagnoses co-occurring at the same time. So one study found that the average number of independent diagnoses for a client with a co-occurring disorder is over 3. So the term co-occurring disorders encapsulates a broad variety of conditions with varying diagnostic severity, complexity, and life impact. This could be chronic and persistent co-occurring disorders This could also be a single or a short duration episode. So if somebody has severe paranoid schizophrenia, they are chronically homeless, they have an alcohol use disorder, and this has been going on for the last 25 years, that would be considered a co-occurring disorder. But if somebody suddenly loses their spouse and they are having an adjustment disorder, that meaning that it is taking much longer for them to go through the normal grieving process, and during that time they are using alcohol to where they meet the criteria for an alcohol use disorder, well, that might be a short duration co-occurring disorder. Once they get some grief and loss therapy, they may move through the mental health piece of that, but that still also would be considered a co-occurring disorder. So that's when it means that co-occurring disorders encapsulate a very broad variety of different conditions and severity levels. So formal diagnosis of a co-occurring disorder requires identifying at least one disorder of each type that exists independent of the other. And it's not just simply a cluster of symptoms resulting from one disorder. So for example, if somebody has a severe alcohol use disorder, they will almost certainly have symptoms of depression. Depression is one of the characteristic symptoms that comes from long-term alcohol use and addiction. So in that case, the client may present as depressed, but as the client moves through treatment, if it is simply the alcohol use disorder, the depression will likely go away. So when we're trying to determine if there is a co-occurring disorder, we're trying to determine if the depression exists independently of the alcohol use. So if the person wasn't using alcohol, would they still be depressed? Now, there's a whole process of doing screening and assessment for co-occurring disorders to try and determine the independence of the two or more disorders, which we'll not be covering in this lecture, but we will cover later on during the semester. Now, note, most of the time, the issue is where substance use is causing mental health symptoms, either while the person is under the influence of the substance or while they're going through the withdrawal process, which could be either acute withdrawal or post-acute withdrawal. There are many different subgroups of co-occurring disorders. So there are some people with co-occurring disorders who have a primary substance use disorder and who also experience some mental health symptoms that could interfere with the treatment and recovery if not addressed. Meaning that somebody may have a very bad alcohol use disorder or a heroin use disorder, and they also have generalized anxiety. Now, generalized anxiety is not debilitating, but it's there. It meets the criteria for anxiety. And so this may be an issue in terms of relapse prevention. If the person used to use alcohol or heroin when they felt anxious, well then if they feel anxious after they've stopped using the substance, there may be an inclination to go back and use the substance again. So that would be an example of where the mental health symptom could be interfering with the substance use treatment. Concurrently, we also have people with primary mental illness whose substance use is causing problems with mental health management. So somebody who has bipolar 1. Bipolar 1 disorder is a severe mental health disorder with concurrent mania, and it is primarily treated from medications and some treatment on emotional regulation techniques. And so many drugs of abuse interfere with bipolar medications. So this is where the substance use disorder may be interfering with the mental health management. And then there are some people who have co-occurring disorders whose histories and symptoms are so complex that it's difficult to determine which diagnosis is the primary one, or it may flip back and forth at various points in their life or their month or their day. The substance use disorder may be the primary concern, or the mental health disorder may be the primary concern. So we treat all types of co-occurring disorders, both primary substance use, primary mental health, and the ones that are very complex. So let's do a couple more review questions. So if a client is suffering from a history of generalized anxiety in social situations, and they develop an alcohol use disorder after originally drinking to lessen her anxiety symptoms, would this be considered a co-occurring disorder? Yes, definitely. In this case, the generalized anxiety disorder came first But then after drinking, an alcohol use disorder developed, and now we have two separate independent disorders, which meets the criteria for co-occurring disorder. So if a client with a 20-year methamphetamine dependence is in detox and complains of hallucinations while he's in detox, is this a co-occurring disorder? In this case, probably not. It's certainly possible that the person has an independent psychotic disorder and the methamphetamine is sitting on top of that. But here, having hallucinations while going through the acute detox of methamphetamine is not uncommon. So here we would have to determine, do we actually have evidence that the hallucinations exist outside of the use of the substance? All right, I'm going to include some research statistics in here to show you how common co-occurring disorders are. So this is a very old survey. It was done in 1994. Typically, we would not cite old research studies in a college level course, but the reason why this one is so important is because it had over 20,000 participants. So generally, the larger the study, the more reliable and valid the results are. The 1990s were designated by Congress and President H.W. Bush at the time as the decade of the brain. And there was a huge amount of government money that was put towards research into the brain, into mental health. And so we had a couple of these gargantuan studies that happened during this time that really kind of stand as the benchmark studies that are very reliable and valid. So this study found that 30% of people who identified with having a mental health disorder also had a substance use disorder. 37% of people with an alcohol use disorder also had a mental health disorder, and 53% of people with a drug use disorder also had a mental health disorder. So what we're seeing is numbers somewhere between 30 and 50%. Now there was additional things that came from additional information that came from this study about people who were currently in treatment facilities. So what they did was they were surveying people who were in treatment for a substance use disorder. And what they found was that 64% of people who were in treatment met the criteria for a mental health disorder. So this wasn't lifetime. This is while you're in substance use treatment, you also meet the criteria for a mental health disorder. 84% of the people who were diagnosed with antisocial personality disorder also had a substance use disorder. That's a huge number. 60% of people who were diagnosed with bipolar disorder also had a substance use disorder. 47% of people diagnosed with schizophrenia also had a substance use disorder. So again, the numbers that we're seeing at the lowest level are in the 30%, and at the highest level are in the mid 80%. This is the reason why SAMHSA has made the statement that mental health should be an expectation in a substance use treatment facility. Most people who come in for a substance use disorder are likely to also have a mental health disorder, looking at the statistics. There was another study that was done in the 1990s, that same decade of the brain, when lots of money was being put towards this research. This wasn't quite as large. It was a survey of 8,000, but that's still a fairly large study, definitely with more likely to have valid and reliable results. And so they found that 51% of the people in that study who had a mental health disorder also had a substance use disorder. And depending upon what the drug of choice was, between 41 and 66% of people with a substance use disorder also had a mental health disorder. So the bottom line is that we are seeing lots and lots of very large studies that show us evidence that the majority of people who are in treatment have both mental health and substance use disorders. It is very common, and it should be an expectation when working in a substance use treatment facility. There are some treatment implications for this also. So if clients with co-occurring disorders are an expectation in substance use treatment facilities, we should note that people with co-occurring disorders are 3 to 4 times more likely to be hospitalized than clients with mental illness only, and 10 to 20 times more likely to be hospitalized than clients with a substance use disorder alone. And people with co-occurring disorders are 10 to 14 times more likely to commit suicide than the general population. That's a huge number. 10 to 14 times more likely to commit suicide than the general population. So we're looking at a group of people that have a very complex history and heightened risk. So the presence of having at least two independent disorders or a co-occurring disorder exponentially increases the intensity of each disorder, the complexity of the treatment issues, and ultimately it tends to decrease the outcome success. So outcomes are measurements that are made to determine whether or not what you're doing is working. Typically, outcome measurements in substance use treatment are if the person completed the treatment program or did they leave early against medical advice. Did they stay sober for a certain amount of time? Say, did they stay sober for a year after treatment or not? Did they return to treatment after completing treatment successfully? So people with co-occurring disorders tend to have much poorer outcomes than people that have either a substance use disorder alone or a mental health use disorder alone. So it is essential for all clinicians working with co-occurring disorders to have knowledge of mental health and substance use. Now, I'm training alcohol and drug counselors. So in this case, we're primarily focusing on learning about mental health. But on the other side, mental health clinicians who are working with co-occurring disorders are expected to have knowledge of substance use treatment, because everybody working with co-occurring disorders needs to be prepared to provide screening and assessment and integrated treatment and referral for clients with co-occurring disorders, and recognizing how much higher risk people with co-occurring disorders are. You need to practice risk management techniques to ensure client safety. All right, so let's talk about the no wrong door policy. So the no wrong door policy was established by a federal task force of substance use and mental health experts, and it was designed to guide co-occurring disorders treatment policy across the United States. So what typically happens with federal policies is funding gets tied in. So if there is a federal policy on something, the way it basically works is that the federal government says, look, this is the policy. So if you want federal funding of any sort, if you are licensed or certified in any way by a federal entity, then you need to follow our policies. And typically what happens is state funding for programs has a portion of federal funding. So what will happen is the United States will designate a certain amount of money, towards some kind of a treatment. So let's say in this case, the treatment of co-occurring disorders. And what they'll do is they'll say, we're going to appropriate money to all of the 50 states. And so California, if you want your share of the federal money to implement funding for programs in your state, then you need to follow our policy. Now, the state certainly can say, no, thank you. I don't want your money. I'm not going to do it. And that actually happened with the Affordable Care Act. So when the Affordable Care Act, or Obamacare, was passed in 2008, there were some states that said, I don't care, we're just not going to take federal funding dollars. And so that can happen, that a state could decide not to abide by federal policy. But in the case of California, California adopted the federal no wrong door policy and considers it a best practice for treating clients with co-occurring disorders. So what does that mean? So prior to the no wrong door policy, somebody with a co-occurring disorder may have moved between programs. So they may have a substance abuse disorder and a psychiatric or a mental health disorder, and they'd try to go to an addiction program or a substance use treatment program. And they'd say, oh, sorry, we don't treat mental health there. And so they deny them admission. And they say, you got to go get mental health treatment. So I say, okay. So they go walking across town, and then they try to get into a mental health program, and in intake, they say that they have a heroin use disorder, and they're like, oh, sorry, we don't treat substance use. You can't come in here either. And so what was happening at the time for people with co-occurring disorders is they couldn't get treatment. They go to addiction programs and they couldn't get in there. They go to mental health programs, they couldn't get in there. And it was an epidemic of people who were living on the street with co-occurring disorders. A huge proportion of the homeless population, people were dying on the street, and it wasn't a case that there wasn't treatment out there. It was that the treatment out there, they weren't able to access. So the federal government established the no wrong door policy in the following principles. So what it said is you cannot exclude people with co-occurring disorders from accessing treatment because they have a complex profile. So if you come to Dr. Burke's substance use treatment facility and you tell me you have borderline personality disorder, I am not allowed to say, oh, sorry, you can't come into my treatment facility because you have a complex personality disorder. I instead have to allow that person into my treatment facility if that's where they showed up. So what the no wrong door policy said is that all individuals needing treatment will be identified and assessed at entry at any facility where they seek treatment. So if somebody with a co-occurring disorder shows up at a medical facility, that medical facility is required to assess them there. If they show up at a mental health facility, then the mental health facility is required to assess them there. If they show up at our substance use treatment facilities, we are required to assess them at entry in our facility. We cannot tell them, sorry, go away. And then you either provide services directly, or you can provide services through an appropriate referral. So the federal no wrong door policy does not require somebody to provide services that they're unable to do so. They either have to provide the services or they have to connect that person to the right services. So if somebody showed up at a mental health facility and they were detoxing off of an alcohol use disorder, if it's not a detox facility, that facility is required to take that person in, assess them, do an intake assessment, figure out what's going on, and then connect them with a detox facility if that's what they determine is the best course of action. What they can't do is say, oh, you're drunk, sorry, we don't serve drunk people here. Because again, at entry, wherever they show up, we assess that person and figure out what they need next. Now, whenever possible, agencies, not individuals, the agencies are responsible to coordinate and integrate healthcare for the client through a seamless continuity of care. This is sometimes referred to as the warm handoff. So let's go back to the example I just gave of somebody showing up at a mental health facility and they need detox. So the mental health facility can't say, oh, okay, come on in, let's assess. Boy, you can't even complete this intake assessment because you're so intoxicated. How long have you been drinking? Like, when did you stop drinking? You know, it sounds like you really need a detox facility. Here, let me give you the name of a detox facility across town. Here's your slip of paper. See you later. Good luck. So that would not be a seamless continuity of care. The expectation with the no wrong door policy is that the agency, whenever possible, will have a handoff so that it's a seamless continuity of care. So the agency in this case may pick up the phone and call the McAllister Detox Facility and say, hi, this is Dr. Burke's mental health treatment facility. I have a patient that came in the door. We've assessed this patient. They're really in need of detox services. Do you have a bed available? Yeah, Dr. Burke, we have a bed available. In fact, we'll send a car to you right now and we'll take the person into detox. Great. We'll keep this person here in our lobby, our facility until you get here. So then they get here, right? We bring the person out to the car, they head off to detox. That's what we're talking about when we talk about a seamless continuity of care or the warm handoff. Now, there's recognition that creative outreach strategies may be needed to encourage clients with co-occurring disorders to engage or continue with treatment. So we are going to assess that client and then try to either give them care at our facilities or transition them to the right facility, recognizing that person may decide not to go. So maybe the person comes in, they're intoxicated, they come into my mental health treatment program, they're intoxicated, I think detox is the best course of action, and they tell me, no, fuck you, I'm not going to detox, and they storm out the door. So at that point, I'm not required to run out the door, tackle them, handcuff them, and drive them across town to a detox facility. So here again, the recognition that creative outreach strategies, building a relationship, motivation for treatment, may be required in order to engage that person to continue forward with the recommended treatment. All right, integrated treatment models. So The old model of treating co-occurring disorders was sometimes referred to as the get sober first model. It's called the sequential model. The idea here is you stabilize the most acute disorder first, and then you treat the other disorder. So for substance use treatment facilities, somebody comes in, they're clearly responding to internal stimuli, they're hallucinating, they're delusional. The old model, the unintegrated model, would have said like, well, we just need to make sure that this isn't because of their cocaine use. So we need to get them off cocaine and let's see what happens. And we're only going to treat the cocaine. So here's the problem. Mental health symptoms and substance use symptoms overlap in co-occurring disorders. And it's often very difficult to distinguish between what's the primary disorder, what's the secondary disorder. Is this disorder being caused by, the other disorder, or is it part of the first disorder? It's very difficult to understand that. And the problem is if you treat one disorder without treating the other disorder, this can increase symptoms in the untreated disorder. So if somebody is using heroin and they have post-traumatic stress disorder and they come into a treatment program and we just get them off the heroin and we don't address in any way the PTSD will absolutely become worse in the process because the heroin was probably helping with some of the acute anxiety that the person was feeling who had PTSD. So the problem here is we're only treating one of the disorders and the other disorder gets worse. They also found that these were the worst rate of treatment outcomes in program adherence. So people wouldn't finish programs, they wouldn't stay in programs. Basically, it just didn't work. So the Get Sober First model is not a recommended best practice any longer because the research shows that it fails. Now, SAMHSA has recommended the integrated treatment model. So there's two versions of the integrated treatment model. The first is the partly integrated treatment model, or the parallel model. In this case, you are treating the substance use disorder in one system and you're treating the mental health disorder in a separate system. An example of this may be that you've got a substance use treatment facility in downtown San Diego. So the client comes into your facility, you assess that they, in addition to having a heroin use disorder, they've got post-traumatic stress disorder, it's pretty acute. And so you're like, well, we don't have any mental health clinicians. We don't have a psychiatrist. We can definitely treat the heroin use disorder. And we'll do that. Like, let's have you come in, let's develop a treatment plan. But we'd also like you to go to the Jane Weston Psychiatric Center, which is a facility here in downtown San Diego. And what we'd like you to do there is get assessed, get an intake, talk to the psychiatrist, talk to the mental health clinician. Let's see if you can get your PTSD treated. So we're going to treat both of them at the same time, but I'm going to focus on the heroin use disorder, and hopefully Jane Weston's going to help take care of that mental health disorder. So SAMHSA recommends that this is a type of integrated treatment. And in some cases, particularly in very small rural towns, this may be the only option that's there. So if you're in a teeny tiny town in the middle of cornfield, Iowa, and you've got a little bitty, substance use treatment facility, and in the town over, there's an urgent care that employs a psychiatrist and a mental health clinician, that may be the best option that you have because it's so small. Generally in San Diego, we are very large and have lots of access to multiple variations of treatment. This is the problem with the parallel model. So the client has to adjust to two different treatment philosophies and develop relationships with two different treatment teams and attend services at two different locations. So they're at my facility for the heroin use disorder, and then they're going across town to Jane Weston and they're treating the PTSD, but they've now got to interact with our counselors and their counselors. They need to get themselves across town. They may or may not have transportation in order to do this. It's very, very challenging for the client. It puts an extra burden on the client. In addition, there's often a challenge communicating and sharing information between treatment teams. So if it's a completely separate organization, well, now there needs to be a release that the client has said that I can share information with Jane Weston and Jane Weston can share information with me. That's not not the case if it's inside of one treatment facility. So if in my treatment facility, there's substance use counselors, a psychiatrist, and mental health clinicians, there does not need to be a release. But if it's an outside agency in a parallel model, there does need to be a release. And so here, we've got to coordinate. I got to call over to Jane Weston. The psychiatrist is never available. You know, she calls over and I'm not available. So there can often be a real challenge sharing information between the treatment teams. So this is acceptable, but this is not recommended as a best practice. So the best practice recommendation is an integrated treatment model. So an integrated treatment model is the dominant treatment model in substance use treatment here in the city of San Diego. So in an integrated treatment model, most substance use treatment facilities have a multidisciplinary team who's treating both disorders in the same system. So again, my facility may have mental health clinicians or psychiatrists who are working alongside the substance use or the alcohol and drug counselors to treat the substance use disorder and the mental health. There are multiple studies and meta-analyses that show that this is the best treatment outcomes, much better adherence to treatment, and generally clients have higher motivation for treatment. So in the integrated model, you accept and treat both disorders as primary, and you help the client develop motivation for change and the skills to manage both conditions. And we treat both disorders as primary from the beginning. So the client that comes in who has what looks like it could be depression and they definitely have an alcohol use disorder, we're going to treat the depression as if it is a separate depression very carefully. We're going to coordinate between the psychiatrist and the mental health clinician and the substance use counselor. The psychiatrist may start on a low-level treatment medication for depression. Let's see what happens. Are the depression symptoms getting less as the person is sober for a long period of time? But we're going to treat both of them primary together. We provide psychoeducation to people with co-occurring disorders about the nature of both disorders. So treatment, integrated treatment means clients learn about mental health symptoms and mental health treatment while they're in substance use treatment. When I'm not teaching at the college, I'm also a clinical director at a treatment facility here in town, and we have groups. We have psychoeducational groups on mental health, where all clients, whether they have a mental health disorder or not, learn about mental health, and in some cases may start to identify and recognize that they have a mental health condition. And we teach about treatment, recovery, and relapse prevention for both substance use and mental health. We'll have a separate lesson on relapse prevention, but it's important to note that people can relapse both on a substance use disorder and they can relapse on a mental health disorder. And the idea then is to reduce substance use and the problems associated with substance use using harm reduction or maintain abstinence from alcohol and drugs. Harm reduction is also considered a best practice for working with clients with co-occurring disorders, particularly people with severe acute co-occurring disorders. We'll have a whole separate lesson on the use of harm reduction later in the semester as well. An integrated treatment model seeks to stabilize acute mental health symptoms, either through the natural remission of those symptoms or through a reduction in the severity of those symptoms. Typically, that's a combination of using medications or psychopharmacology and supplemental counseling. And then we plan for, intervene, and address the process of relapse for both substance use and mental health symptoms, including the development of a co-occurring relapse prevention plan. This will be a project that you all work on later on this semester, where you'll develop a relapse prevention plan that addresses both mental health and substance use in the same plan. Another part of integrated treatment is to improve the cognitive, thinking, behavioral, acting, and interpersonal coping skills for the person to assist and facilitate symptom management. Is typically primarily emotional regulation, and address some of the problems that are contributing to or resulting from the co-occurring disorders, like say housing or the inability to hold a job, and promoting obviously a positive lifestyle change. So going back to pharmacology or medications, it is extraordinarily important to provide medication to control mental health symptoms, especially during early recovery. Many times, if people are not taking medications for mental health symptoms, it will cause the mental health symptoms to become more acute, and it can then interfere with the person continuing and completing their substance use treatment. So typically in an integrated treatment model, medications play a large part, particularly during early recovery. Go back to my example about depression and an alcohol use disorder. It may be that the depression is being caused by the alcohol use, but typically when a client comes into a substance use treatment facility, we will look into medications to treat the depression at least first, because there's recognition that depression as a symptom may cause the person to relapse, and so we want to treat that depression. Now, it doesn't mean that the person will be on medications for depression for the rest of their life, but they may be on medications while we try to tease out what it is that we're actually working with. Now, sometimes that requires an attitude shift about medications and sobriety. Many people have beliefs that I don't believe in psychiatric medications. Some people may have a belief that taking certain medications, somehow means you're not sober, even if a doctor is prescribing you that medication for a co-occurring disorder. So it is important to note that failure to address and support client medication for co-occurring disorders is considered unethical, meaning that whatever your personal views are, this is a best practice approach based on lots of research that people typically do better in early recovery when medications are included. Again, that doesn't mean that they necessarily mean to stay on medications for the rest of their life, but denying the client medications or telling the client, I don't think you should be on medications, would be unethical, because by not supporting client medication, this can prolong suffering and it may interfere with or even prevent recovery from a psychiatric disorder. So in terms of the alcohol and drug counselor with medications, you cannot prescribe medications, but you absolutely can talk with clients about their medication and support medication compliance. And what I mean by that is that you, as the drug and alcohol counselor, or I'll use an I statement. So I'm the drug and alcohol counselor. I meet with my new clients, first time I'm meeting with them, and I say, wow, great. I read the intake, and just want to review some things. So I noticed that you said that you have bipolar disorder. Yeah, I have that. Like, oh, and what kind of medication do you take for bipolar disorder? Well, like the psychiatrist wants me to try lithium. Like, oh, lithium, okay. So how long have you been on the lithium? Only for a couple weeks. And so how's it working for you? I can totally have this discussion. It's appropriate. It is providing an opportunity for the client to talk about the medications, asking if it's working or not working for them. Client may tell me it's not working for me, man. I hate this. I don't want to take my meds anymore. Okay, whoa. Well, let's not stop your meds until we talk to the psychiatrist. But let me reach out to the psychiatrist. I'll let her know that you're really struggling with this. Maybe we can get you in to see her in the next couple of days. So we support medication compliance. We talk about medication with the clients. We inquire about whether it's working or not, and we can deliver information to the rest of the clinical team. Now, a side note about a couple of particular medications. So if you are in California, it is state law in California. Down at the bottom of the PowerPoint, I actually have the statute in the State Code of Federal Regulations that says that a substance use treatment facility cannot deny entry to a potential client based solely on the individual having a valid prescription from a licensed healthcare professional for a medication. This includes medications for narcotic replacement treatment. So methadone, buprenorphine, which is sometimes referred to as Subutex, or buprenorphine with naloxone, which is sometimes better known as Subutex. You cannot deny a client entry into a substance use treatment facility solely because they're on Suboxone. Not in California anyway, that is illegal. They can shut down the treatment facility for doing that. Now, if a person comes into your treatment facility and they are abusing their Subutex, or they come in and they're on 16 milligrams and they're falling asleep in groups and they're slurring their speech and they're unable to participate, that's a whole different story. Then you can address the behaviors, the concerns about this, ask that the person talk with the psychiatrist because they're unable to participate in their own substance use treatment. All of that is valid, but you cannot deny them entry into your treatment facility because they're on a medication. This was something that for a very long time was happening here in San Diego and across the country. There were some treatment facilities that had very strong belief systems that if you were on some kind of narcotic replacement treatment, then you weren't sober and you couldn't be in treatment. By state law, you cannot do that any longer. All right, so a couple of review questions. So if a homeless person with schizophrenia and chronic alcoholism shows up at your treatment facility, you can send them to detox first and then provide integrated substance use and mental health treatments. Totally, right? Without question. So they show up at your facility and they need detox. That doesn't mean you need to treat them there. You've assessed that they need detox, and so you connect them, hopefully through a warm handoff, to a detox facility. Then they come back, you definitely can provide them both substance use and mental health treatment in your facility, assuming that you've got the capacity to do so. A person can relapse into mental health symptoms just like relapsing into substance use and can benefit from a mental health relapse prevention plan. Totally. So people may have mental health symptoms and they stabilize. They don't have those symptoms anymore, and then they come roaring back. There's many variations of this. Somebody might have suicidal ideation or thoughts about ending their own life, and then they get treatment for depression. Those thoughts have gone away, but they go through a very difficult period of time 3 years later, and suddenly they're thinking of ending their life again. That would be considered a mental health relapse, and you can develop a mental health relapse prevention plan, same as you can a substance use relapse prevention plan, to anticipate this happening and figure out what you're going to do if it happens. All right, the primary treatment models and skills for treating co-occurring disorders for the counselors. I'm not going to go into great detail about each of these because there are separate lectures that I have that cover each of these in that level of detail. But first and foremost is the importance of forming a therapeutic alliance. So having empathy, understanding and attempting to understand the person, their thoughts, their actions, and perceptions is always the first part of doing any kind of counseling. Relapse prevention is the best practice for co-occurring disorders, both mental health and substance use. Motivational interviewing, solution-focused counseling approaches, harm reduction, contingency management, which is a type of behavioral therapy, cognitive behavioral therapy, and dialectical behavioral therapy are all considered primary treatment models for co-occurring disorders. Now note, it is generally much more difficult to engage clients with co-occurring disorders. Typically, clients with co-occurring disorders have the highest dropout rates of all clients in both substance use and mental health treatment. And they also typically have the highest rates of substance use relapse, which is usually coinciding with some kind of a mental health relapse. So we also need to recognize that many clients with co-occurring disorders are ambivalent or they have low motivation to change, because the attachment to the substances actually may be providing some symptom relief, and there may be a denial of psychiatric diagnoses because of stigma. What I mean by that is that the client with PTSD may be resistant to stopping the use of heroin because the use of heroin does, for some degree, provide them some relief from their PTSD symptoms. Or maybe the person denies that they have schizophrenia. There's a lot of stigma associated with schizophrenia out there in the world. I've personally had this experience with a number of clients who clearly met the criteria for schizophrenia, but didn't even want to talk about it, denied they had it, and didn't want any kind of psychiatric help or medications. And so that then leads to lower motivation to change. If you're being told that you should treat both of these things, and for some reason you don't want to treat one or more, then you're typically going to be resistant to any treatment interventions. So usually the primary or first treatment intervention when working with co-occurring clients is to try and increase motivation for change. And sometimes this is the only accomplishable treatment goal, is to try and get them to being motivated to try and address the two conditions that are causing them stress. So a significant portion of the clients who have co-occurring disorders, again, I kind of covered this in the last slide, generally refuse to admit that they have a problem with both disorders. We're going to treat them anyway. So treatment motivation, inconsistent attendance, failure to take medications as prescribed, these are all very common problems for clients with co-occurring disorders. And so it's important for us then to make adjustments in forming a therapeutic alliance to try and have empathy and understanding for why the person is feeling less motivation for treatment. why they don't want to take their medications as prescribed, why they're having inconsistent attendance to our treatment groups. So typically, motivational interviewing is the go-to. The first thing that we're going to do when working with clients who have co-occurring disorders to try and increase the motivation for change. Students in the AODS program at San Diego City College get a lot of training in motivational interviewing. It's also recognized that mutual self-help or peer support groups are extraordinarily beneficial for people with co-occurring disorders. This is the use of peer support groups, Double Trouble, Dual Diagnosis Anonymous, groups that are very similar to like 12-step support groups for substance use disorders, where people with co-occurring disorders can talk to other people who have co-occurring disorders about what their experiences have been and what's worked for them. And significantly, people with co-occurring disorders, we often have to make adjustments to our treatment plans and have more realistic and attainable treatment goals. Sometimes just having somebody who's able to get to group at least twice a week when there's 3 groups a week being offered may be an initial treatment goal. Can I get you to commit to that? In many cases, we need to modify what constitutes success or failure for clients who have co-occurring disorders that are significantly impairing their judgments and functioning. In some cases, you know, I worked with some clients, I worked at Father Joe's Villages for over a decade, and I worked with some clients with severe persistent mental illness who had been chronically homeless for decades, and they ended up in a permanent supportive housing apartment with a case manager collecting SSI disability income, and they're still smoking pot, but they weren't out there, you know, using crack. And this is something that's enabling them to get along well with their neighbors, and they're not using anything else, and their mental health symptoms are at least tolerable. And in those cases, sometimes those were considered a success. It was a modified, attainable treatment goal. So strategies to improve treatment adherence include using motivational interviewing, normalizing and accepting that they're ambivalent to change, accepting that they're in various levels in the stages of change. You learn a lot about that in the AODS program at City College. Like a pre-contemplation client, you're going to work with differently than you would a client who's in an action stage, for example. And then addressing motivational and adherence problems when they arise. So if somebody is coming to group late, or they're missing individual sessions, or they're not taking their medications, it doesn't mean that we don't address it. We definitely need to address it and try and figure out what's going on, what's the concern, how can we help. It's also important to prepare the client for what to expect in treatment. When you have somebody who is ambivalent or in a contemplation or pre-contemplation stage, it's important to let them know, hey, this is what this entails. This is what our program offers. Talk about any concerns they might have before they actually enter the treatment program. And identify any obstacles that might be causing problems for them. You know, the client with a co-occurring disorder is like, I'm not going to no 12-step meetings. I'm just not doing that, man. Like, no way. Those people don't like me. I'm not accepted there. Like, I'm just not doing it. If you make me do that, then I'm not doing treatment. Okay, well, that would be an obstacle, right? We should talk about that before the client starts the treatment program and see if we can come to some sort of a compromise. So what we're looking for ultimately is to negotiate a treatment contract or a treatment plan that the client's agreeable to follow. Attending to the therapeutic relationship is the most important factor. I mean, really, it's the most important factor in any kind of treatment, but it is certainly extraordinarily important when working with complex clients. So expressing empathy and concern, conveying a genuine desire to help is all really important. Facilitating the transition between levels of care. So many clients have challenges when they move from, say, an inpatient residential treatment program to an IOP intensive outpatient program. It's particularly challenging for people with co-occurring disorders. So you want to really be acutely aware of transitions and anticipate any potential problems that may develop from that, and be a powerful voice on the multidisciplinary team. When I worked at Father Joe's Villages, we had multiple levels in that program. It's a huge program. And, you know, we had people who were leaving a treatment program. They were in one of the temporary housing facilities into a permanent supportive housing facility. And, you know, sometimes the administrative and residential folks are like, oh, well, great. I mean, they've been sober for 6 months and they'll have a case manager and everything will be awesome. And as the drug counselor, sometimes I was like, okay, whoa, like, hold on though, let's talk about this. This person's now not going to be in a supportive environment. They're going to have access potentially to people, you know, selling drugs nearby. What are we going to put in place in order to support this person? Okay, so my review question: a court-ordered veteran client with PTSD and heroin dependence enters your treatment facility. He doesn't show up for the initial intake and then argues with the counselor about the group requirements. This client should be told that it appears he is not ready for treatment and to come back when he is willing to commit to recovery. So that is false. That would not be considered a best practice approach to somebody with a co-occurring disorder. Instead, we need to address the treatment resistance, the ambivalence to change, prepare the person for what it is that the expectations are, address any obstacles that may come up. All right, that takes us then to the end of this presentation. So this is a long introduction to co-occurring disorders, but this is a very complicated group of people that we work with. So this will form kind of the foundation of working with co-occurring disorders, what alcohol and drug counselors are expected to do when working with clients with co-occurring disorders, understanding things like the no wrong door policy and the requirement to take people in and assess them at whatever point they enter. And then some of the things that we do to help improve treatment adherence and ultimately the treatment plan. Till next time.